Well, good morning or afternoon, depending on where you are. Brandon Garrett here with the National Minority Quality Forum. Glad to have you back. It's been about a week or something with all the holidays at the beginning of the year, and so it's good to be back. And so since you've had a bit of a break from us, we're going to just go ahead and let our CEO lead this discussion. It's an interesting topic that actually we've been working on at the National Minority Quality Forum for some time with Gary and Gretchen, and it's a first for CMS establishing coverage for Alzheimer's disease treatment, and it's going to be a lively discussion. So with that, I'm going to turn it over to Dr. Puckrein.
Thank you, Brandon. Good afternoon. Please join me in welcoming Amanda Barthelemy. She's Executive Director of Policy for ISAE. The forum congratulates ISAE on FDA's traditional approval of Leqembi, the first disease-modifying therapy for Alzheimer's disease. It's a big deal. Amanda, thank you for joining us today to participate in this discussion. The National Minority Quality Forum's interest in this issue is not academic. We have devoted significant time and resources to improving the quality of care for individuals with Alzheimer's disease and related dementia. During the past 15 years, we have engaged on this issue, including creating and maintaining the Alzheimer's Data Index. And for those of you who don't know, we've been mapping Alzheimer's down to the zip code level now for over 15 years. Coordinating a successful multi-year initiative to create more precise ICD-10 coding for neuropsychiatric symptoms of dementia and staging of severity of Alzheimer's disease. And just last month, presenting an oral public comment to the FDA Peripheral and Central Nervous System Drugs Advisory Committee in support of traditional approval of Leqembi. And Gretchen Wortman has really been a force behind all of those activities with our Brain Health Alliance. So we've had a really deep commitment to this. And again, we're pleased that Leqembi received traditional approval from FDA. We and the stakeholders who are joining us today are now very interested in hearing from you, Amanda, regarding the process that CMS is implementing to fulfill its commitment to create access to Leqembi in that way. And in their words, enables the collection of real-world information to study the usefulness of these drugs for people in the Medicare program. For our audience, please enter your questions for Amanda in the Q&A box. After Amanda completes her remarks, we will address as many as we can, including a few from me. So, Amanda, let me turn it over to you. Just by reference, for those who don't know NMQF, we are a research and education group based here in Washington, D.C. And we love talking about innovative therapies and are really excited about the work that ISAE is doing. So Amanda, turn it over to you.
Thank you so much, Dr. Puckrein, and thank you to NMQF for all of the work you do on behalf of patients with Alzheimer's disease. This is such a, I think it touches a lot of our lives, and it is truly a team and community effort to care for patients and to find treatments and cures. So I think ASI is very proud of the moment we're at now with having traditional approval for Leqembi, but we also recognize that it takes all of us to move things forward. So appreciate all the work you do, all the work Gretchen does, and all the work we'll continue to do moving forward together. I am happy to be talking today about how CMS has acted post FDA traditional approval for Leqembi. So as a bit of background, in April of 2022, so we'll go back a little way, CMS put a policy in place for Medicare coverage of all disease-modifying agents or all monoclonal antibodies directed at beta amyloid for the treatment of Alzheimer's disease. Say that 10 times fast. So for all of these types of drugs that target beta amyloid in patients with Alzheimer's disease, CMS decided to apply a coverage with evidence development standard for these drugs, being that drugs that received accelerated approval from FDA, they would only cover in the context of a clinical trial, a randomized controlled trial, And once the drug received traditional approval based on clinical endpoints, CMS then said they would cover, but still want to collect more evidence via a registry or other prospective study. They also, over the past several months, so Leqembi received accelerated approval in January of this year, and then just on July 6th received traditional approval. And as CMS promised, they expanded coverage via a registry on July 6th for Leqembi. I would encourage folks, if people haven't been following this as closely as, say, I have in my everyday job, CMS has put out a whole host of resources to explain their decision, but also talk about how this is going to be operationalized. And CMS promised in the months leading up to our traditional approval that they would offer broader coverage for anyone needing the FDA labeled indication for the drug at the same time that FDA acted. And they did really deliver on those three factors, which we really applaud the agency for doing that. How they did that is that CMS stood up their own registry that providers need to enter data for their patients into in order for, in this case, Leqembi, but for any monoclonal antibody for Alzheimer's disease that could be also approved in the future, would also fall under this same policy. There is a great video that they posted. There's a YouTube video you could watch. It's about 4 minutes long that actually walks through the registry. So you can see step by step what physicians will need to enter or what physicians' offices will need to enter in order to fulfill this commitment on data entry. There's also a provider fact sheet and a patient fact sheet for folks who have questions. So I found those to be very helpful as well. In terms of patient access, they did not put any restrictions on coverage other than the FDA label. So the FDA label is you need to have a confirmed diagnosis of Alzheimer's disease, be in early stages of the disease, and have evidence of beta amyloid. And that's the standard that CMS is using as well. And we were happy to see that because it means that there aren't limitations geographically, by provider type and other things that we've seen in past registries that have been run for other technologies and services through CMS that might limit folks to, say, an academic medical center that's able to run a study that's being mandated by the agency. In this case, they truly are looking at sort of real world evidence, meeting patients where they are and allowing providers that are Medicare providers to treat their patients and supply this data. I'm trying to see what else we can talk about the registry here. So the registry looks like it'll be about a 5 to 10 minute endeavor to enter the data. Providers will need to update the data every 6 months because one of the goals here is to see how patients do over time on these treatments. And they're asked to input data every 6 months for 2 years for a total of actually 5 data entries because you do a baseline and then every 6 months after there. CMS plans to analyze the data and publish their results. They have also said that they would allow, so they stood up their own registry, but under this policy, they're also allowing other members of the public, other researchers, if they would like to bring forward a study or a registry to be added under this sort of umbrella policy, folks are able to do that. And we actually saw a second registry added just this week on Tuesday. CMS approved another registry through Beth Israel, and the details of that are up on the CMS website as well. So it's great to see these access points for patients that they're really delivering on that. We know that over the next weeks and months, since this is the first time for CMS to implement a strategy like this, in some ways, we're learning as we go. So we look forward to working with CMS, with members of the Alzheimer's community, with caregivers to, make sure that patients continue to have the appropriate access. That we know already there are often many barriers within our healthcare system to access care, and to ensure that this serves as not a barrier, but maybe even an access point that it doesn't impede access in any way. I will pause there and see if any questions have come up. Happy to give more background, more detail wherever folks need to be. Again, this policy is now 8 days old. So I will tell you as much as I know and as much as we've learned. We do know that patients were eligible to start receiving drug under Medicare coverage as of July 6th. But CMS has asked physicians to not start submitting claims until July 25th. As they're getting their systems ready to process those claims. So I think between now and the 25th, we might see some more guidance on, some of the nuts and bolts particulars on how to submit claims, what data is needed, and just how those are going to flow through the system. But this has really been an exciting time for Alzheimer's patients and for caregivers, and we're looking forward to, getting the right patients on treatment in a timely fashion.
So you mentioned the web video. Do you know the address, or can you give us the address and we'll get it out to folks? You don't have to do it right now, but if you tell us the address.
We can. Yeah. I should have it memorized, but I don't because I have it bookmarked. But I can.
Okay, no, that's fine, because I think folks would love to go and take a look at the video.
If you go to cms.gov and click on Medicare, I think it's still within the press release column on the right hand side. You can scroll down to it.
Okay, all right, great. Folks will take advantage and look at it. So this is not Eastside's registry. This is CMS's registry. So,
correct.
Yeah. So some of these questions that probably at the end of the day probably need to go over to CMS. But let's try to see how much we can help folks right now.
Yeah.
So question: how does a provider learn about this? And because let me back up and ask the question this way. First question is, does a provider have to enroll themselves into this registry?
So no. The way it's set up, and this is my understanding as it is, and we might get some clarification from CMS, but the way it's set up now, the portal is available. You can click on it. What you need to have is a NPI, or a national provider identifier, which is your billing number for Medicare. So if you're a Medicare participating provider, you enter your number in and it pulls up your information. And that seems to be the only enrollment you have to do, is really to be being enrolled as a Medicare provider makes you eligible to enter data in.
Great. And so you're entering in the patient, I presume, and do you know what other information they're requiring of the provider?
Sure, I will give you this at a high level.
Okay.
So it's the provider number and the beneficiary number are the two things that you sort of have to de facto know to drop in. And from there are question and check boxes and drop down menus. You have to identify the drug that's being used. Right now, Leqembi is the only one in the drop down menu because it's the only approved product. But in the future, we anticipate there'll be more. You need to report on when beta amyloid was confirmed, the date of that, and the results of that test. So again, that's just to confirm the correct diagnosis. There are then some questions around use of anticoagulants and anti-thrombotic drugs. There's a question around cognitive testing that was done, the date of that test and the results, as well as functional testing. And there are some questions around adverse events. Have you seen evidence of ARIA or ARIA-E or ARIA-H, which are the known, one of the known complications and side effects seen with these drugs that, again, are being monitored for. It's part of our FDA label that there's ongoing monitoring to watch for that. So when there's evidence, that gets entered in the database as well. And I believe that's the last question. There might be one or two more, but those are the details. And CMS notes, and this feels very accurate, that all of this data should be in the patient's medical record already. So it's really a matter of, just reporting on the standard of care that's been delivered and entering it into this database. So I think it's easier for Medicare to access in that way than having to do like a chart review for all of these patients. So it's really an efficiency concept.
And then if I'm understanding you correctly, the clinician will then periodically have to go back in and update the data.
Correct. Every 6 months. Every 6 months.
Every 6 months. Okay. Right.
Yeah.
What I find intriguing too is that you're mentioning that the registries for beta amyloids generally, is that just Alzheimer related beta amyloid or any?
Alzheimer's disease. These are for I think the full name is monoclonal antibodies directed against beta amyloid in Alzheimer's disease.
Gotcha. Okay.
Yeah.
All right. Great. So my following question then would be, so how are clinicians going to find out? How do they know about this in order to prescribe?
That's a great question. And that's something I think CMS has done a good job, I think, of making announcements about this. But we are also, if folks call in to ASI's resources around prescribing, we are able to direct them to this website and inform them of that. I think it's on all of us to make sure folks are aware. So because it is such a new concept, I do think it's helpful too that this has gotten a lot of popular press. So we've seen this in a lot of media channels. So hopefully prescribers that are interested in treating their patients have been following some of that too. And I think the Medicare decision has been fairly prominent in a lot of the headlines and things. So hopefully it is not a secret, but we certainly have resources to direct folks in the right way. And I think hopefully the Medicare administrative contractors who claims get submitted to, they will also be pushing out information to their providers just to explain to them what the requirements are as well.
And I've been around enough of my clinician friends, so I'm going to ask the question that they would ask. This is uncompensated in the sense of them filling out the registry for their patients is not compensated time.
That is correct. I think that's true. This is additional administrative work. I think CMS did their best to keep it the time involved to be as short as possible. I think they really went for a streamlined approach as they had publicly stated they wanted to. There's also no fee associated with enrolling in or joining the registry, which I know was a concern in the months leading up to this, that typically, oftentimes to participate in a registry, there's a cost associated, like an actual out-of-pocket cost versus just a lost sort of compensated time cost. So there is no fee associated, which I think is also helps with that issue of it.
And what happens, again, I know you're not CMS, but I'm sure these are questions that folks are thinking about. So how does CMS maintain compliance? Meaning doc comes in, fills it out, and then forgets to follow up 6 months later or whatever that is. What happens in that instance?
That's a great question. And I think it's a great question for CMS, how they're going to plan on enforcing that or giving reminders to providers to make sure that they're collecting the data they need. We haven't seen guidance on that yet, but I think we'll see guidance on that in the future. These are the types of questions that I think are really important to continue to feed back to the agency as they roll this out. And I think we'll, again, since I said this is the first time we've seen something like this, that it's going to be an iterative process and we'll see refinements over time.
And is anticipated that these will be neurologists who are doing this, or is it primary care going to also possibly subscribe?
I think that's a great question. I think that is not being mandated by CMS, but I think from a clinical perspective, we anticipate that it will mainly be specialists initially, just because of the level of care and expertise that's needed even to get a patient diagnosed. I don't know how many primary care or general practitioners feel comfortable getting to this diagnosis, and you need some fairly sophisticated testing to confirm beta amyloid, either through a PET scan or a spinal tap or a blood-based test. You need to have the MRI, the baseline MRIs, and the monitoring going on. So the degree to which PCPs have the ability or have access to those levels of treatment, there's nothing that prohibits them at this point. But I think more from a clinical structural perspective, we anticipate it'll be specialists, at least initially.
Yeah. And CMS though is not requiring the PET scan evidence or anything like that, or they at least asking, did you do one, or how
they're requiring that you enter that the beta amyloid was confirmed. They're not saying it has to be via PET scan or a different test. The clinician can decide the best path for that, but you need to enter into the database that you did in fact confirm beta amyloid presence, which is important because these drugs don't work if beta amyloid isn't present, since that's what they target. So we want to make sure that they're going to patients that they can be helpful in.
Yeah. And you know us, we're obviously very interested in the diversity issue here, and how is CMS? How are they going to regulate or identify or make sure of? I don't know what the appropriate language is here, but
That's a great question, and I think that is an ongoing challenge. I know you are aware of this, not just in the case of this registry or this disease state, but more broadly. I think it was a concern going in, and CMS stated this in their national coverage decision, that making sure that treatments were reaching, diverse populations, underserved populations is a concern. And I think the way they set this up was very mindful of that by not limiting access only to academic centers or only to very specific specialists means that the reach of this can go further. I think the existing barriers are there, but the way they structured this data collection won't exacerbate those problems. So I think that's helpful. But I do think there's lots of work to be done in identifying patients sooner in the course of disease so that they can benefit from treatments like this, and making sure everyone who needs it has access to the right types of care teams to get the care they need.
I'm sure that the medical community will weigh in and have thoughts on this. But looking from afar, it does put a new burden on the clinician in order for them to have access to this, particularly of those we think of them as minority serving, in this case, neurologists. They tend to have a lot more Medicare and Medicaid beneficiaries in their practice. So time becomes essential for them, because just by the way those programs reimburse. And so I would assume that CMS is paying attention to that.
Yes, and I think it's, again, that's one of those important things to be continually feeding back to the agency. I think everyone is approaching things with the best intentions, but sometimes as things play out and get out into the real world, we find out how things are really working, and being able to give feedback and hopefully improve processes is essential. I mean, in this case, but in all cases.
So how is Eastside planning to work here? I mean, I guess you're part of this new model, as you say. How is Eastside? How are you thinking about this?
I mean, it's an interesting position for us to be in, because as you said earlier, this isn't ASI's. This isn't our registry. This isn't our portal. We don't own this, but it is clearly very directly impactful on access to the therapy we've brought to market. So we're supporting patients and providers in making sure that they know that the CMS resources exist, how to get to those. And we're also keeping an open dialogue with CMS as we receive questions, as we hear things from our provider community and patients, that we're making sure that we're also feeding those questions back or those concerns back to the agency so that they can continually improve processes. But we are cautiously optimistic that this will not serve as a barrier to access for patients who really need therapy, and that it won't be overly burdensome to providers that are caring for these patients.
And so is it likely that ESI will do physician education about the registry with some of your folks going out to clinicians and helping?
That is a great question that I think we're still grappling with internally, since again, this is all new to us as of last Thursday as well. So we're trying to figure out the best way to be helpful and to, you know, amplify it and highlight messages that are coming out of CMS and what the right role for us is versus what the role of the agency should be.
So, obviously NMQF, we interact a lot with the patient community, and I can say that there's a lot of anxiety about this inside the patient community. I'm talking about the patient advocacy community now.
Yeah.
About these ideas of registries and why this particular drug gets selected when there are lots of drugs that come out of FDA that CMS reimburses for that doesn't have this sort of requirement.
I think those are the right questions to continue to be asking and to continue to explore, you know, among the patient community and with the agency, because I think I agree. Those are the questions we need to ask, and we need to continue to press on, you know, the whole community to make sure that we're not putting unnecessary barriers in place and that we're truly focused on access to safe and effective treatments.
So typically on our call, we have a lot of patient advocates. I'm sure we've got some listening to you right now. And so I guess the way I'd phrase the question, hopefully ASI won't be uncomfortable with their advocacy, because I think there's some real concerns within the community about what CMS is doing, both in terms of the registry and the collection of data, because I guess the point is, didn't FDA do this? I mean, didn't you guys go through this? And so we're a little lost as to, you know, what is CMS doing now that FDA had not done?
I think that's a great question to continue to ask. And I think, you know, ASI and I think the pharmaceutical industry more broadly, we're continually focused on data collection, building evidence, learning more. Like that's sort of the lifeblood of certainly ASI, but certainly the industry more broadly. And I think we need to be open to any avenue to collect more data and to collect data in good ways and to learn more. So if this proves to be a good way to understand how drugs are working in the real world, that's wonderful. If this proves to be not a great way to find out how drugs are working in the real world, we need to revisit that as well. So I think we need to see about how, you know, this activity, the data we've already built for our clinical development program through FDA, our ongoing data commitments to FDA for post-market studies and such, how we can collectively look at all of this evidence and look at this sort of totality of evidence and what we can learn about drugs. So I think it's going to be important for that sort of sharing and transparency across different agencies, different platforms, different methods of data collection, because I think the more we know, the better, and not keeping things siloed is really going to be the key.
So is CMS going to grant access to this data? Will ESI, for example, have, as this data is collected, will ESI?
CMS has stated that this data will be available for researcher activity and for access. So I don't know, this is one of the things I haven't had time to look at very closely yet, but I think we'll see more guidance on how folks can go about using this data. But CMS has stated their intention to make this available.
So I'm going to, again, you're sort of in the unfortunate place because you're not CMS, but I'm around the patient advocacy community enough to understand of some of the stuff that's bubbling up. So CMS is now gathering data on patients, right? And I'm not hearing that these patients have been consented. The physician is putting this data in and if I was a clinician, I would have concerns about privacy as well as HIPAA regulations and everything else that goes along with this. Again, not Esai's question, but I'm just telling you what I hear within the patient advocacy community about. So I think CMS has some clarifying to do, particularly if they're going to make use of this data. And I'm not sure how they're doing it, but I think it's a really important question.
Yeah, I think those are. I will first state by saying I'm not a patient privacy or HIPAA expert in any way, shape, or form, so I'm not going to weigh in on any of that. But I do think that that's a question I've certainly heard and echoed here throughout the community, and I think CMS is working quickly to get clarifying information out. So hopefully they're hearing that too and can put out some more information, because they did state, there've been a series of press releases, and they did state in a previous press release that any data collection and research activity would meet all of the standards of privacy and protection and patient protections. So I know that intention's there. I think they just haven't clarified how that's being handled, and things like de-identifying data and things on the back end are I think common practice, but hopefully we'll see some more guidance coming out from that.
I'll say it back to you this way. If Gary Puckrein and NMQF opened the portal and said to physicians, put your patient data in here and we're going to collect it and we're going to share it around. Anyway, it's an unusual process. And I'm assuming that they're thinking their way through it. So we'll wait to hear what becomes of that. But long story short, it's at least some patients are going to have access to this medication. But there's another side of the ledger for those patients who their physician that they go to either don't know or are unwilling to participate in this process. And so it's to be understood that the therapy will not be available to them right now. Is that sort of the long and the short of it?
Yes, I would agree with that.
Okay. And will CMS give counts? I mean, obviously, we'll want to know what the uptake on this is. So will CMS give counts presumably at some point?
I know there are plans to report out interim data that's listed in the materials that CMS posted. I don't know how. I believe that's a couple of years out. It is at least like 18 months out that we might start to see data proactively out of the agency from what they've said so far. But I think that's another good question that I'd be hopeful that the agency would be really transparent with that as well, if folks inquire.
Okay. We've got a couple of questions in the chat that I'm going to do this. I think someone has put on the video link. I assume that's the video link for the.
Oh, good. People are being helpful.
Yeah, in the chat. So for those of you who want to see the video, I believe there's a link in the chat that you might have. So someone's asking, does Medicare cover the cost of the other cognitive tests, the amyloid plaque detecting test? Because I'm assuming all of these come with the usual copays and stuff like that. PET scans, for example, ain't cheap. And so the traditional costs, I'm assuming the patient will have to assume the out-of-pocket side of this.
That's correct. So the services involved here, I believe, are all Medicare Part B covered services. So the standard 20% co-insurance for beneficiaries would apply, and that goes for the testing and monitoring, physician office visits, all of the things that are required. So to the extent that patients are, exposed to that full 20%, For Part B services, that would apply here. Folks with Medigap policies or who might be dually eligible for Medicaid or have other secondary insurance, their out-of-pocket would be reduced by those secondary payers. In terms of, I know there's been some questions around particularly the MRIs, the PET scans, some of the other sort of advanced imaging that's needed as monitoring here. PET scans in particular are a challenge, given that there's an existing NCD with CED for PET scans with a limitation to once in a lifetime and needing to be enrolled in a registry and a trial. CMS is in the process of reconsidering that or opening up that for reconsideration. They were going to do that late last year and then paused that. They publicly said that they were going to pause that process until there was more data available, that they were aware of some new information coming to the fore. I would assume that this drugs approval is probably part of that calculus that they're weighing in. So I've seen reported that they are looking to move to reconsider that NCD. There's been some press reporting statements out of CMS that the MRIs are covered as reasonable and necessary services. So those sorts of tests should be covered as typical services. But to your point, there is an out-of-pocket associated with those.
Someone has asked, many families are having difficulty in getting their loved ones diagnosed. Is there a registry, or will there be a registry where family can find physicians so that they can be accurately diagnosed?
That is an excellent question that I do not know the answer to, but we can look into that. I'm not. I know there's some services available or some places to find infusion clinics, but to find a neurologist or another team to get diagnosed, I'm not aware of. That doesn't mean they don't exist. It just means that I have not been asked that question before.
And you just said something really important. So, and I should have remembered, so these are infusion drugs. So the patients will have to go to the infusion centers, and there'll be a cost for the infusion out of pocket for the infusion side of this as well.
Yeah.
So someone is asking about the cost. I think it's largely irrelevant for this conversation. So what's your anticipation? I mean, how does Eastside feel about this? That obviously in the ideal circumstance, you'd like to be treated like a traditional drug, and CMS does what it's supposed to do. But here you are. So what's your sense of this?
I will say, yes, in a perfect world, we would not be having this conversation at all. But that's not where we find ourselves. And I think CMS has been very forthcoming in their intentions all along. They have, over the past year plus, they put the policy in place. They've been asked to rescind it. They have said, no, we're keeping this policy in place. They've, stated that a registry or some sort of data collection would be needed. They stated publicly, that they would align access with FDA approval. They stated that it would be broader access. And they have truly kept to the spirit of all of those promises, which I would say, personally, I am encouraged by that CMS has told us what they're going to do, and then they've done what they're going to do. So I think that's encouraging. And again, I remain cautiously optimistic. I was also, it's also nice to see that they've written into this policy sort of an endpoint. They talk about data collection through, 2 years for each patient, and then looking at the data and assessing, which hopefully there can be a sunset on this policy when CMS sees enough data and feels comfortable with that. But I think that's a conversation we're going to need to continue to have to figure out, are we asking the right questions? Are we asking them the right way? And is this, is this a good use of resources and serving the right purpose to get good answers for patients? And I think that comes back to our earlier conversation too, about not just looking at the data being collected here, but looking at the total amount that we know about these products as they're in the real world, as they're being used in broader sets of patients, and getting a better understanding of the benefit they're bringing.
So, you know, in the traditional world, a product like yours comes to market, it gets used in the clinical setting, and papers get published. And so there's a body of literature that quickly bears out. And historically, in the minority community, for example, because we've not been in the clinical trials, that's how the evidence was generated once a product came to market, in terms of both its safety and efficacy in many instances, was determined in the clinical setting. And so is this an attempt to accelerate that by seeing? I'm just kind of trying to understand a little bit broader, what's the purpose here?
That is a great question. And I think, so we're talking very specifically about this policy, but CMS has talked a lot more, there's new policies out around CED and how they're using that in general, that's open now for comment. They've also expressed interest through CMMI, so the Innovation Center within CMS, about addressing health disparities, getting better evidence on minority communities, underserved communities. So I think there's a real commitment by the agency. And I think this could be a piece of that implicitly, but I think they're also trying to explicitly do a lot more to get better evidence on more representative samples of patients in this therapeutic area, but across the board.
So there's some questions about prior authorization. Is a formulary going to be part of this as well, or are they exempt from formula? First of all, this is the Part B medication, isn't it?
Correct.
Yeah,
So this is a Part B drug. So within Medicare Part B, there is no process for prior authorization. So that is not going to exist for sort of traditional Medicare beneficiaries. And there also aren't formularies in Part B. So this is now a nationally covered drug under this CED policy. In terms of Medicare Advantage plans might implement prior authorization or other criteria. So we'll have to see how they apply that, but they still need to meet the same standards set for access within fee-for-service. So if they have a prior authorization, it couldn't be more restrictive than coverage on the other side of the Medicare population.
So what you're saying, if you're a patient enrolled in Medicare Advantage, you don't escape the registry. The doc will still have to enroll you.
Well, that's a good question. That's one we're still trying to work through. How I think there's nothing that prohibits Medicare Advantage patients and providers from being entered into the registry, but I don't believe the way this is my understanding. So this could change. We could get more guidance out of CMS. I don't think it is required that Medicare Advantage lives are put in there. So I think that's one of these details that needs to be worked out. And I know that's something that the MA plans are currently trying to sort through as well, to understand what their specific obligations are to meet these standards.
And what happens to the dual eligibles? I'm assuming that they would be subject to this as well?
Yes, if Medicare is your primary payer, that's definitely you're subject to this policy.
And does Medicaid then have to pay the copay for these patients? Is that how it would probably work?
That's how it would work. As it typically works with any Part B service, that Medicare would be your primary payer, and then Medicaid would come in as a secondary payer and address out-of-pocket obligations.
You said something else that I wanted to follow up a little bit. You said that Medicare is going to look at the data over 2 years. Is that the aggregate data, or is that the individual patient level data? I mean, that they're going to look at and make a determination. So what are they looking at here?
I believe that's a great question, and I don't want to speak out of turn on that one. I think that I would have to look at the trial protocols that so there's a protocol that's listed within the CMS website. We need to dig into that a little bit more, just to understand how they're going to analyze the data. But I believe that's already posted. I just have not dug into that piece.
And I think I'm correct in this. So Medicare is doing this under the platform of reasonable and necessary. So what they're trying to understand is reasonable and necessary, and that's why they have these registries. Is that it?
That's correct. That's correct. So the first layer of determining if something is covered by Medicare is reasonable and necessary, and CMS has sort of established the CED process to allow for access when they're still determining if something is reasonable and necessary as a means to answer that question. That's sort of that's the construct of CED. That's the conceptual framework we're working within.
Okay, all right. And so I think you made the point earlier that right now you're sort of first in line, but the intent is probably certainly to look at other of these anti-amyloids, because that's why the system is being set up. So anyone coming to market will get the same sort of requirement.
Correct. Any product that receives traditional FDA approval would be subject to this.
In this class.
Yes, in this class specifically. So for example, Aduhelm is FDA approved under accelerated approval. Should they receive traditional approval from FDA, this policy would apply to that as well. We know Lilly has a product in development that could be, reviewed by FDA in the coming months, and if they receive traditional approval, it would apply to that drug immediately as well too.
But the medications approved under accelerated approval will not.
Correct. Correct.
Fascinating. Okay.
Because if it's under accelerated approval, they will only cover under a randomized controlled trial. So it's a bit of a higher bar for evidence generation during that phase of approval. That's how the coverage determination is structured. Okay.
And then, we talked a little bit about physicians learning about this in the registry and that sort of thing. How will patients learn about this, or their caregivers or whomever? How will this information get shared?
I think that's a really interesting question. And I think that goes back to the questions earlier around patient consent and patient, even informing patients that this exists, because the way it's structured, this really could be done and be invisible to the patient, because the physician is truly kind of transferring data that's in the physician record into this portal. They don't necessarily have to do it in front of the patient or let them know. So I think that's a discussion about, is that a good thing or a bad thing? And depending on patients, level of comfort with that, I think that's something that needs to be thought through.
And what's your guess? I mean, how long will this program? Because when we look at coverage decisions, I'm thinking about TAVR right now, valve replacement. That's been going on for a lifetime. I mean, I can't imagine that anybody does a study as long as the TAVR study. Continue to look for evidence. Is this is this never going to go away, or is it sunset at some point? How does this get managed?
I remain cautiously optimistic that we can work with the agency to answer the questions in the CED and sunset this policy. But I think that's a question that's going to be ongoing. They did write into this policy more of an endpoint that we've seen in previous policies, but we'll see how this plays out. So I think that's a great question, and one that we will continue to revisit.
Theoretically, the next generation of medications in this class could perform at a higher level. I'm sure you guys are working on things that will come through traditional FDA approval, but they'll still be subjected to this no matter what the evidence that comes out of FDA. Is that a fair way to say?
I think the answer to that one is it depends. I think it'll depend on the mechanism of action and the target of future therapies. So this is very specific to drugs that target beta amyloid. Now we're going to get way outside of my as
I
a
was thinking,
non-clinician
yeah,
and non-scientist, but
yeah.
I know that there's something that targets tau or takes a different approach to
Right.
treating Alzheimer's might not fall under this policy because it's very specific to the beta amyloid agents.
And someone's raised a great question here. So what's happening in the commercial space? How are the private sector folks thinking about this? How are they going to make this available to patients?
So private insurance plans aren't bound by this at all, and they weren't bound by this previously. We do see generally, and not just in this case, a lot of times commercial insurers will wait to see what CMS does and follow suit or establish coverage around the same time. So we have had commercial insurers covering during the accelerated approval period in a limited fashion. I think again, it's been 7 days, but I think we'll see sort of an acceleration of access now that Medicare coverage is more defined than it was even a week ago.
But you wouldn't anticipate, or maybe you do anticipate, a private insurer setting up a registry and then requiring the private folks to go through something like this?
It's a great question. I don't know. I think depending on how this gets to sort of interoperability of medical records and electronic medical records and things, but I think depending on the payer and the type of payer, they might have a means to cull this sort of data even through claims or other ways. If you look at like an integrated delivery network or something like that, they could do this sort of data collection already and not necessarily have to set up a brand new data collection portal.
Are you suggesting that they could
I'm thinking
maybe
of
kind
like,
of deal with CMS and use CMS as a registry?
they could, but I'm also thinking, if you think of like the Kaisers of the world, they are a closed system. They have a lot better means of sort of looking at data and collecting information on their patient population because it's sort of self-contained. But I have not heard that any commercial insurers would be setting up registries. But
what about the VA? Is the VA going to follow CMS? Or they have different policy?
So the VA is its own system, and they had set up their own criteria for use and policy actually earlier this year. And so they've had coverage parameters in place since earlier in the year for veterans to access therapy. Again, that's a good example of a closed system that's able to do some more interesting things with their own data and their own management of access.
Interesting. So we live in the patient advocacy world. So my patient advocacy friends are going to beat me up for probably not being as bringing all of their concerns forward. But I would say this, that certainly this medication is being tiered, right, by this approach. Because you're going to have folks who are going to have access because their docs are willing to take the time and get them into the registry and make sure that they have access to it and do the necessary follow-up. The out-of-pocket costs are going to be there as another set of challenges. And I've heard docs say that I don't think the patient can pay out of pocket, and so therefore I'm not going to prescribe. And in this case, I'm not going to go the extra step because I know that the patient is not going to be compliant on this medication. So they could start them off and think that they're not going to be compliant on it because of the out-of-pocket costs that are associated. So there's a lot going to happen here that CMS is opening the door to. That is going to create differential risk for patients that I think they're not taking into account, or maybe they are taking into account, depending on how cynical I want to be on what day.
Yeah, I I would agree with everything you just said. I think it's already a challenging patient journey to get care. It's challenging to get to a good diagnosis. It is a time intensive and can be cost intensive process, given all of the steps you need to go through, even to get diagnosed, and then to go from there. This is not by any means a we talked earlier, it's an infusion. It's a every other week infusion. So there's a commitment by patients to being committed to that therapy. It's a 1 hour infusion, so it's not it's lengthy, but it's not a day-long infusion. I mean, there's everything's relative.
Yeah.
Right. Everything's relative, but I think you're exactly right, and that's something we do need to watch closely. Does this seemingly, on its own, low burden registry added to everything else, does that have an outsized effect in getting access for patients? So I think you're adding one more piece to an already complicated system.
Yeah. And I always think, again, with my patient advocacy hat on, CMS needs to be very explicit about how it's managing patient privacy, how it's enrolling patients into a study, because this is a study, without informed consent. I think these are issues. This goes back to Tuskegee, right? This is sort of the world that African Americans have lived through and have constantly been concerned about. So it's on CMS. I mean, they're the ones who are creating this, and so it's on them to help everyone understand how they're putting this together, understanding both the ethical and privacy issues that are associated with it, and also the management of care that they are going. I would suspect, and I don't, what do I know, that there's going to be a large number of patients that are not going to have access and get the benefit of this medication, and are going to proceed more quickly onto late stage Alzheimer's disease as a function of the way in which CMS has decided to do this. And it borders on clinical care. They're bordering on making clinical care decisions for these patients. And so I think the advocacy community is watching carefully, and we want to be supportive, to make sure patients have access to it. And then just for the minority community, we want to make sure that they don't get left behind in this. We're at time, and I don't know if anything you'd like to add in closing for this. Well, first of all, I want to thank you for your incredible patience and answering questions that are not Eastside's making. You're living in a world created by CMS, and so we appreciate your candor and patience with these questions.
Well, I just want to thank you for having me. I've really enjoyed the conversation, and I think I'm glad that people are asking these questions, and we need to continue to ask them. And as I said, sort of at the top, like, this is going to be a community effort and continue to be. So we do need to all keep talking to each other and keep talking to CMS and moving forward. So I think you're asking all the right questions, and hopefully we will continue to get answers as we walk this path together and with CMS.
I want to thank you and your colleagues at Eastside for novel therapy, badly needed for communities that really have had nothing. And so we're deeply appreciative of it. And we'll do all we can to make sure that every patient who should have appropriate access to the therapy gets it. So we at NMQF will think out of the box as much as we can to be supportive.
Wonderful.
Well,
thank you so much.
Thank you. Bye-bye.